like to welcome you and thank you for joining us today for our webinar, which is highlighting our newest publication just released today, which is titled Progress and Promise, Interprofessional Health Training to Deliver Patient-Centered Primary Care. It's a fantastic report that we're thrilled to finally be able to share with you. It highlights how 7 different programs from multiple states, California, Illinois, New Mexico, North Carolina, Oklahoma, South Carolina, Texas, and Virginia, train a variety of different health professionals to work together as teams with patients and students in patient-centered medical home settings or advanced primary care settings. I'm going to be providing today a general overview and some major takeaways from this new report. And then our guest, Dr. Barbara Brandt, who directs the National Center for Interprofessional Practice and Education, is going to be joining the discussion to talk about how several of these training programs have specific efforts underway that realign clinical practice together with interprofessional education. And so if you'd like to go and download the report now, we invite you to do so. You can do that at our website, which is PCPCC.org. And as you're doing that, I'm going to quickly go over just a few announcements and housekeeping items. So first, announcements. Just to give you an update, as you know, we have a new Congress that will be beginning in January, and we're going to be hosting a briefing on Capitol Hill on Friday, January 30th from 11:30 to 1 p.m. We will then be releasing our latest evidence report, which is going to be titled The Patient-Centered Medical Homes Impact on Cost and Quality, a Review of the Evidence. The event is open to the public, but space is going to be limited, so please go to our website and you can register for that Capitol Hill briefing on Friday, January 30th. And the housekeeping issues really relate back to our webinar. Many of you have participated in our webinars before, and so you're familiar with the format, but we do ask you to use our software in order to ask questions or to provide comments. In order to do that, you need to submit your questions in writing using the drop-down question box that's on your screen. And then during the last 15 minutes of our webinar, Tara Hecker is going to be facilitating some Q&A with all of you. And so please do keep your questions at your side and write them down and share them with us, and we look forward to that conversation. Finally, as many of you know, we do record these webinars and post them to our website within the next 24 hours, so you can revisit the webinar or share it with your colleagues. So with that, I'm going to go ahead and get started, and I'm going to have you look to our slides, and you will see that, again, the title of the publication I'm sharing with you today, Progress and Promise, Profiles in Interprofessional Health Training to Deliver Patient-Centered Primary Care, is the topic of our webinar. As I mentioned, I'm going to be reviewing this publication, not in great detail, but hopefully whetting your appetite some so that you'll be encouraged to go and look at the report yourself. We're going to be highlighting those 7 champion programs and discussing some of the lessons learned, and then I'll turn the conversation over to Dr. Brandt, and we'll end our webinar with some Q&A from the audience and some closing remarks. Next slide. So in the fashion that the PCPCC so often likes to work, and that is with a big group of collaborators who are passionate about advanced primary care and patient-centered medical homes, the goal for this particular publication was fairly straightforward, and that was to advance interprofessional primary care education by selecting some terrific innovative programs and then telling their stories. And the case study model is one we like to use at the PCPCC, and we like to include as many collaborators as is possible. So you'll see a list of those collaborators here. We invited folks from as many health professions as we could garner to join us on our quest to to create this publication. And you'll see that what they did in a collaborative fashion was identify programs that used effective strategies to train students in advanced models of primary care. We pulled these programs from the number of innovative programs that had been shared with us via our education and training database. We have a database on our website that now has over 130 different innovative programs from across the country. We invite any of you who have not yet done so to visit our database and tell us more about your innovative health professions training program, and perhaps we can follow up in a future publication and highlight your work. Next slide. We do want to acknowledge the terrific teamwork that really across health professions and organizations that was embraced. And you see the report reviewers, Timmy Adbar-Barwick with the physician assistant organization, Cynthia Villar with the psychologist, Barbara Brandt, who will be speaking with us shortly, Stacy Collins with the social workers, Jessica Holmes, Stanley Kozlowski with family medicine, and Scott Shipman with the AAMC. We did have the PCPCC's Education and Training Task Force, the co-chairs being Dr. Bill Warning and Cynthia Villar from the American Psychologists Association, help us lead this effort early on. And then we had a number of terrific folks help us review all 130 programs in our database and help us determine those programs that we were going to be able to highlight for the publication. So you see Cynthia, Amy Dawson, Susan Day, Melissa Galuli, Margaret Temecki, and Manisha Verma. The writers for this particular publication, Stephen Pelletier and Krista Sera, and then our editors and design, Jennifer Selipik and Elizabeth Jones. But I can't give acknowledgments without giving a special shout out to the woman who really made this entire thing happen, who worked many, many nights and weekends on this labor of love, and that's Tara Hacker on our team, who, as you know, is the director of our programs and just does a phenomenal job. And I think this is a favorite, if I do may say so myself, her most favorite project she's had an opportunity to work on. Next slide. Providing just a little bit of context for what we're discussing here today, not all of the programs that you'll be hearing about have a fully functioning patient-centered medical home, but all of the programs have components and features that relate back to the patient-centered medical home. And for the purposes of the webinar, I think it's important to just define specifically what that means. We do use the AHRQ's definition of a PCMH. You see that nicely elucidated here on the slide. Patient-centered, person-centeredness being key to a PCMH and really the foundational element of a PCMH, but also a focus on care coordination, care that is accessible, with a commitment to quality and safety, and focused on comprehensive care that is whole person and provided by a team of individuals. Next slide. The story of interprofessional education in this country is in some ways a very long one, and unfortunately in some ways still yet a short one. I myself have worked in several academic medical centers and served as a faculty member for 6 years at the University of Kansas Medical Center, where we're all trying to do better at training health professionals together. But the reality is that really the energy and emphasis on interprofessional education picked up real steam in 2009 with the creation of the IPEC, the Interprofessional Education Collaborative. You'll see that the folks who formed that collaborative were themselves health professionals from from different fields to include the American Association Colleges of Nursing, the American Association of Colleges of Osteopathic Medicine, the American Academy of Clinical Pharmacists, the Association of American Medical Colleges, the American Dental Education Association, and the Association for Schools of Public Health. So really a broad group of health professionals who came together to think about what the competencies for interprofessional education needed to look like. Then you'll see a number of key things happening across the last several years. 2010 with the World Health Organization releasing a framework for action around interprofessional education and collaborative practice. In 2011, the IPEC then released its core competencies for interprofessional collaboration, and you'll see that reflected in our report. And in 2011, the PCPCC's Education and Training Task Force took a look at those competencies and crosswalked them against what we believe are core competencies of patient-centered medical homes. At that point in time, we put out a survey and asked innovative programs across the country to tell us more about what they're doing around interprofessional education and the competencies that their programs embrace. And then in 2013, we incorporated all of this information into a database. So we took the survey, put it into a database, and then, as I mentioned, our reviewers analyzed the information that was included in the database and pulled together 7 different programs that we then did an in-depth set of interviews with to learn more about how these particular programs operate. Next slide. We give you a little bit of information about our education and training task force. I've already mentioned some of this work, so I won't reiterate it here. But just to point out that education and training task force does continue to meet and focus on, in particular, what team-based training means and what it should look like, how we could advocate for it, not only in the world of health professions training in academic centers, but also we're very interested in what training looks like for frontline workers and people who are already working in practices. Those folks get together and meet as part of the Education and Training Task Force via quarterly phone call, but we suspect in the coming year we'll be elevating some of this work as we continue to focus on workforce and having them work closely with our centers. And again, they were really the impetus for the publication that we are releasing today. Next slide. I've mentioned the database that we have at the PCPCC, and not only are we interested in folks going to look at that database and entering information about their own program, but really use this program to meet your needs when it comes to thinking about how you might be able to search through different programs and learn information that you think is particularly relevant to the work that you do. So we've made this database searchable, and you can look at a variety of different metrics and measures to find those programs that are most applicable to meeting your study questions or curiosity. And we hope that folks on the phone do that. Visit not only the publication, but also the database, add your information, but search through the database and see what you might learn that helps advance patient-centered medical home and advanced primary care in the setting in which you work. Next slide. And now on to our report. Again, progress and promise. It's on our website now. We will be putting out a press release that shares this publication with the public. It is free and downloadable, and we hope that everybody on today's webinar not only downloads it, but shares it with your friends. Next slide. And I want to stop very briefly and talk about the 7 champion programs that we highlight in our report you'll be able to read about each of these programs in more detail. You can see these programs are from all over the country, West Coast to East Coast, and they highlight a number of different kinds of programs. So not just physician training programs, but psychology, social work, pharmacy, and nurse practitioners, nursing, etc. You'll see that each of these programs integrates health professionals, and I'm going to tell you more about that. Next slide. When it came to selecting these particular programs, we did go back and look at the set of competencies that crosswalks the IPEC interprofessional competencies with what we believe are patient-centered advanced primary care competencies. And you'll see these 16 interprofessional competencies highlighted as part of our report. We believe these competencies are critical for preparing health professionals to practice in the team-based coordinated care models like PCMH. And they range from things like expectations around patient-centeredness all the way to quality and safety. And again, these particular competencies we think are important not only inside of these academic programs that are training the health professionals of tomorrow, but that these competencies are being embraced by practices that are working, taking care of patients and their families today. Again, you can go and look at our database of the 130 programs and learn more about these competencies. Next slide. We try to share with you these competencies in a couple of different ways. And if you're looking at the full report, if you go to page 7, you'll see that the programs that we selected really incorporated the vast majority of these 16 competencies. Under each of the programs, you can see which competencies the program particularly embraced, and that allows you to kind of quickly see who's doing what in a graphic format. I'll say that the two competencies that most of these programs still struggle with, and something that I think the healthcare marketplace struggles with, is first an assessment of the biopsychosocial needs across the patient's lifespan. So that's something that we're still talking a lot about and trying to figure out, and that is how do we incorporate behavioral health, mental health into primary care across the patient's lifespan. And then secondly, and we hear this from practices all across the United States, and that is, what are sustainable financial business models for doing this kind of interprofessional, team-based advanced primary care? And you'll see when you look at the competencies, really only 2 out of the 7 programs feel like they have sustainable business models, which is going to be something we're going to be focused on a lot over the course of the next year. Next slide. Again, the number of health professions that were included in this program range from nursing, nurse practitioners, internal medicine, PAs, family medicine. Again, I won't read you all of the folks on this slide, but just that we tried to be as broad as possible when we were focusing on which programs we wanted to select. And the icons do a really nice job sharing that information with the reader quickly. Next slide. And as I've mentioned, I don't want to go into too many details about these 7 fantastic programs, but I do want to entice you to go and read about them. Barbara Brandt will be discussing 3 of these programs as well in her presentation. I'm going to start with the New Mexico State University program, which was a counseling psychology program, a fantastic set of very interesting ways in which this program works in the community and is focused on the treatment of chronic illness and focus on integrated primary care. You'll see the folks here that they incorporate in their program and the kinds of patients that they serve, predominantly Hispanic and uninsured, and then the kinds of folks that they graduate from their programs: family medicine residents, counseling, psychology, and nursing, as well as social work, public health, and pharmacy. Next slide. Next, the University of Texas Austin School of Social Work. Again, this is a program that was focused on vulnerable patients, those adults with mental illness, chronically ill and homeless, Spanish-speaking and low-income families. The provider and practice type that the folks in Texas were working with were federally qualified health centers. And the program participants are largely master's students in social work, but of course these social work students are working with a full range of health professionals to include family medicine, nursing, psychology, social work, and pharmacy, and they do receive Title VII HRSA funding in this particular program. Next slide. The University of Oklahoma College of Pharmacy program. Their focus here is integrating pharmacists into the delivery of primary care, and you'll see there are, again, vulnerable patients that are being served as part of this program, 60% being Medicaid, many being poor, minority, foreign-born. The folks who graduate from this program are pharmacy students, but other interprofessional education students as well. And then they provide services in a family medical center, in a Tier 3 patient-centered medical home, as well as in primary care practices. Next slide. The San Francisco Veterans Administration Medical Center, which takes care of veterans of all ages and socioeconomic status. Their program participants range from internal medicine, nurse practitioners, pharmacy, social work, psychology, nutrition, really an impressive group of students that they train there within their VA medical center. And you'll see in our program evaluations that we'll be sharing in January as part of our evidence report. We'll be highlighting some of the fantastic work that's coming out of VA medical centers all across the country that's focused on patient-centered medical homes, what they refer to as patient-aligned care teams. Next slide. The I3 Population Health Collaborative is a really interesting group of family medicine residencies. It started in 3 states and now has extended into Florida. It's a tri-state learning collaborative. Terrific, innovative leaders who are part of the I3 Population Health Collaborative. And in order to be a part of this family medicine and internal medicine collaborative, all of the participants have to agree at the outset that they are willing to change their entire curriculum. They do train multiple professions across this program, so although they're largely focused on family medicine and internal medicine, they partner with pediatrics, nursing, nurse practitioners, psychology, pharmacy, social work, medical assistants, as well as patient educators. And just a few more practices, programs to highlight: the Northwestern McGaw Family Medicine Residency, which practices in a teaching health center, an important program that was developed as part of the Affordable Care Act that we hope to have funding extended beyond next year, and as well as the FQHC program. You'll see the patients that they're serving are also vulnerable patients, and they work with family medicine residents as well as social work interns and psychology externs. Again, terrific work that they're doing to serve traditionally underserved folks. They receive HRSA funding for 5 years as part of, as I mentioned, the teaching health centers from the Affordable Care Act. And their real focus is on training culturally competent physicians. And then our final program is the Harbor UCLA Family Medicine Program. They're training family in a family health center in an ambulatory practice site they're focused on fellows, an interesting program really trying to take fellows and take them out of their training and focus them on the core competencies of PCMH and how to be leaders in that particular environment, so that when they leave their residency and their fellowship, they can go and, for lack of a better word, proselytize about the model. I did just want to end by talking about some of the hallmarks that we saw across all 7 programs. It would be no surprise to you, given what we selected as the competencies that all of the programs needed to have in order to qualify for eligibility for this publication. But first and foremost was this focus on patient-centered care and the collaborative decision-making with patients and their families, having a sense of cultural sensitivity and community focus. You saw that across all 7 programs in a way that was extremely important when you think about where people live and work and play, and how they take what they've learned from a primary care setting and incorporate into their personal life and into the life of their community. Next slide. 3 other hallmarks of excellence were that all of these programs were focused on continual improvement. They weren't just interested in box checking and trying to achieve accreditation for PCMH, but really how they could continue to get better. They all embraced this notion of dispersed team leadership and recognized that there's increasing evidence that when teamwork really works seamlessly, you are really driven by the specific needs of the patient rather than traditional hierarchies when you're thinking about driving team leadership. And then finally, they were very much focused on how to best integrate behavioral health. But as I mentioned, this continues to be a real challenge for practices today who are taking care of patients. And then finally, just opportunities for improvement. Next slide. It should be no surprise to anybody who is embarking on this work that there are insufficient resources and challenging logistics to make this happen. The lack of time and money is just one of them. When you think about training students, there's also a real challenge around simple things like the fact that medical students and nursing students and pharmacy students all aren't on the same academic calendars. So how do you train these students together when many of them aren't even operating under the same academic timeline? So simple things like that are far from simple in changing in an academic environment. We're working under outdated financial models that as you've heard the PCPCC underscore many times, focus on volume-driven care rather than value. And so if we want to embrace these programs, we're going to need to finance them differently, both practices that are treating patients today, but also in the interprofessional settings in which we currently train students, reforming graduate medical education being a terrific place to begin. We haven't done enough to integrate patients and their families into how we train students today. We're doing better and better at integrating patients' wishes and preferences and making patients the center of care. But we aren't yet using patients together with students as part of the health education training process, and Dr. Brandt will be talking more about that. And then finally, technology's promise is in many cases still unfulfilled. And so using technology is imperative, but we need to have programs, technology, information, whether that's EHRs or population health management, that really allow data at the fingertips of practitioners as they're trying to work with patients. And then my final slide, other opportunities for improvement focus on a lack of standard and meaningful measures to not only determine whether that this is working for the students, but is this working for patients. We still have a very blurry relationship then to understanding how what we do in a clinic relates to patients' health and patient outcomes. Engaging students is difficult when they are constantly rotating through their programs. So that's something that we can learn from these 7 champion programs on. And then there's a real need to scale up these programs and so that we can reproduce them. And all of them expressed some skepticism about how easy that is to actually do. And with that, I would just again thank Tara, thank all of our collaborators who participated in this project, and turn this over and thank Dr. Barbara Brandt, who was one of our terrific collaborators.
Okay. Thank you, Marci, for both inviting us to be a part of this project and also a part of this webinar. And I can say that for us at the National Center, this was a very satisfying project to be a part of. And your last slides is actually a very good segue into what we learned from the project and what I decided to call my webinar. And that is what we observed is that these sites think and act differently in what we call the nexus. And I think as I get into my presentation, you will understand why we name the interface between education and practice the nexus. So the National Center for Interprofessional Practice and Education is a cooperative agreement with HRSA, and it was awarded to the University of Minnesota by a competitive process. And then we have private funders, the Josiah Macy Jr. Foundation, Robert Wood Johnson Foundation, Gordon Betty Moore Foundation, and then the University of Minnesota is a full partner in this partnership. And so our goal in the National Center is to provide leadership, evidence, and resources needed to guide the nation on the use of interprofessional education and collaborative practice as a way to enhance the experience of healthcare, improve population health, and reduce the overall cost of care. And you will recognize that that is closely aligned with the Triple Aim, the Institute of Healthcare Improvements Triple Aim. So I too want to acknowledge Tara, Steve, and Krista. They are the ones that conducted the interviews, and we were invited to sit in on it. I'll describe that a little more. But what I'd like to say is this was a high-functioning team. It was a temporary team. It was virtual. They never met each other in person. They developed roles and responsibilities and their own communication patterns of how they were going to work together and get work done. So they were a good exemplar of a team. And then Krista she is a graduate of the University of Minnesota School of Nursing, and she took every course, every faculty development, every opportunity to learn more about interprofessional collaboration that we had to offer, did her DMP project on interprofessional work, and currently she's moved on to the University of Pittsburgh. But I do want to make sure that I acknowledge them as the center of this work. So I'm going to talk about the National Center involvement, what is the nexus, what we learned, and what we have as recommendations for the future. So as you've heard, these practices were selected by PCPCC, and we were invited in after the selection. So we did participate in the interviews with the eye towards learning more about the presence of interprofessional education and what we call the nexus, or the alignment of interprofessional education with clinical practice redesign. This is what we believe needs to happen for interprofessional education to be successful in this country. And then we were asking the questions is, what are the characteristics of these sites that display both, as reported in the interviews? And then we wanted to articulate, as we did in the publication, the themes that we heard to inform new development. So I'm not going to go over this. You're the experts on patient-centered medical homes. Usually the audience I speak to really don't know what this is. I don't speak to your audience. But as you look at, and as Marci described, this is thinking differently. This is thinking and acting. It's very palpable when you go into these practices. I worked for 6 years in clinical practices, and when I go into a patient-centered medical home or practices that are moving in that direction, you can see visibly the change in culture. You see dashboards on the wall, you see huddles, you see front desk staff leading meetings, and frankly, we don't teach that in higher education. I early on recognized that we needed to prepare students and residents very differently to go into these types of environments because we tend to be in an academic tourism mode, as Marci described, just sending students in for rotations and their clinical skills. So we need to be thinking very differently about how we prepare students so that the healthcare delivery system is not retraining our graduates once they leave our programs. It's stuck. Can you advance the slide, please? So this is the definition of interprofessional education that we use in the National Center. It is adapted from definitions long-standing by the Center of the Advancement of Interprofessional Education in the UK and the World Health Organization. It's when 2 or more professions or students learn with, about, and from each other to enable effective collaboration and improve health outcomes. So what's very important about this definition, that it's intentional, it's professions coming together, really having an intentional conversation to enable effective collaboration, and very importantly, focused on health outcomes. So in the National Center, as I described, we are focused on bringing education and practice together in the nexus that leads to partnerships, and we are very interested in studying how interprofessional education and collaborative practice has the potential to impact the triple aim. And we are very much focused on moving from the focus of the healthcare delivery system to the focus on health. But we also call it the triple aim of alignment. So at the same time, working towards improving the quality of education, of experience for people, families, and communities, but learners at the same time. Learners and the team and patients sharing responsibilities for achieving health outcomes and improving education at the same time, and then reducing cost and adding value in healthcare delivery and education by this new alignment. So the World Health Organization also has a definition of interprofessional collaborative practice, which is when it occurs when multiple health workers, and we add, and students from different professional backgrounds provide comprehensive health services by working with patients, families, caregivers, and communities to deliver the highest quality of care across settings. So again, very, very consistent with the work of PCPCC. So going into, as we brought up the National Center, this was what we believed were going to be the elements of the nexus. Integrating clinical practice and education, importantly in new ways, partnering with patients, families, communities, again, the triple aim, but very importantly that students and residents are integrated into the team in meaningful ways, and that there is a shared resource model, and we encourage leadership in all aspects of the partnership. So through the interviews, these were the 3 programs that we thought, at least in the interviews, displayed some characteristics of the nexus. And it's not that the others did not, it's just that it did not come out as strongly in the interviews. So it allowed us to go back and really analyze what was going on in these programs, and we did follow-up conversations with them. So I'm going to describe the themes that came out of this work. So it actually allowed us to refine the definition of the nexus, which we now believe have these elements. It's clinical practices in transforming systems that partner with health professions education programs. They think and act differently, not just in clinical practice, but how they incorporate educational programs into their clinical, in their clinics. They are learning organizations that support continuous professional development, and all of the characteristics that Marci shared fall into this characteristic. And then importantly, educating the next generation of health professionals. So these are the themes that we heard. They share a vision. There is the patient-centered curriculum came out in all 7, but I'll describe also with these 3 what we heard. There's no question innovation for culture change in bringing together education and practice. They talked about spontaneous team leaders and benefits of the nexus to both the practice and to students and residents. So sharing a vision, we learned and we heard that there is an extraordinary commitment to workforce development between the practices and the partner health professions education. They were creating a new culture. So they were able to articulate a common purpose and strategies to address significant barriers, and Marci hit it on the nail. So they work hard to understand and meet each partner's needs and perspectives. They bridge the culture of academia and practice to create a new one, a shared understanding. They describe that this does take significant eyeball time or face-to-face time, and frankly, it's often unpaid. And it is about building relationships, trust, and working appreciation for one another. So this is very definitely not easy work, but they were able to articulate that they had a vision that bridged the 2 sectors. Can you advance the slide, please? So what came out very strongly is the patient-centered curriculum, which really isn't a surprise in these environments, but very much able to articulate that the curriculum starts with the patient in mind, not just the clinical practice. And they were able to describe, do not start with what the practice needs, do not start with what the curriculum needs, but start with the patient. And that being a patient-centered medical home or advanced primary care practice helps with the relevant educational program. So some of the successful strategies we heard was do start with the patient first and then incorporate the learner. Develop a shared decision-making partnership with patients. But what's really important is that can be role modeled then with the needs and wants of the patients for all learners. So being, again, very explicit about that aspect of the work. Then we heard a lot about innovation for culture change. And as you start to make these types of changes, no question it's about culture change. They explicitly articulated the essential role of site champions. So again, people, this is a passion, not just the clinical part, but bringing education into the clinical aspects of the work. There is definitely, and I heard it earlier in the webinar, a commitment to a fundamental shift away from a traditional hierarchical model to be a more innovative, team-based approach. Not only is this critical for transformation of clinical practice, but how we incorporate teaching and learning strategies to learn in practice how to function in teams. So really learning about teamwork in practice, it benefits all. But the other part that I just loved was that small changes add up. This is really hard work, and what we learned from these sites is sometimes it's the little nuanced changes that make big changes in culture. So that one of the descriptions was just simply moving conversation and team meetings from one part of a clinic, which was traditionally the physician's area, to the nursing area. This finding probably has had the biggest impact on me personally. I visit a lot of clinics. I was in a clinic in New York recently, and I again saw this small change. It was as simple as a patient having a high blood pressure, putting the blood pressure cuff on the computer keyboard to signal to the primary care provider that this patient needed a little more attention. That was a change that was a medical student recommended, and it was the medical assistant that actually implemented it. Spontaneous team leaders. we heard that when you shift to this patient-centered curriculum and practice, that there is a role for collaboration. You learn about collaboration and conflict resolution skills. These teams were able to articulate that. And by doing so, it promotes leadership no matter which profession you're in or where you are in terms of employment in the clinic or whether you're a clinician, student, or a resident. And then by doing so, you're naturally learning new skills and practice. So the last two is we heard about the benefits of this new partnership or the nexus to the clinics. So we heard that this benefits, this approach benefits the whole site, including all clinicians and staff. It's like a pride of joy, or a being pride of this type of partnership. And that students and residents bring new ideas about interprofessional education and collaborative practice. So there's a vibrancy now in curriculum as the IPEC competencies, as noted earlier, have been implemented nationally. Lots of training is going into it, now being written in accreditation standards. There's no question that wave of stimulus of competencies and accreditation is starting to show in the doors of these clinics. And then we heard about that students ask really tough questions about efficiency and effective patient care. Then we did hear about benefits of the nexus to students and residents, that when students are intentionally trained in skills needed in practice, they are, by even evaluation, more collaboration ready and confident, that they have marketable skills which are needed in the healthcare delivery system today. And one of the sites actually explicitly talked about being prepared for practice in underserved areas. We sense this in all 7 of the sites. And I might say many of these sites do have HRSA or have had HRSA funding. And then the students naturally learn how to address barriers in practice because they have role models that they are seeing who are living every day in ambiguity. So our take-homes is that as we're think about what would we tell sites getting ready to embark upon this is how do you engage in dialogue with your sites, educational programs, and others to explore what is working, gaps in practice, barriers to progress. So that dialogue is essential. Start with the patient in mind. To strengthen the nexus, how do you identify and engage in opportunities for partnership, and really designing around the principles of a patient-centered medical home benefits the nexus. And there's no question we learned that significant commitment to a shared vision could potentially benefit all. So this is our advertisement in the National Center. We too have a resource exchange, a website. This is how you can get on it. And we will be also putting this webinar on our website and resource exchange. So I very much want to thank Marci and your team for inviting us to participate. It's advancing our understanding of the work, and I look forward to continuing.
Great, thank you, Barbara, and thank you, Marci. I want to launch question and answer with our audience. So just a reminder, to ask a question, you just need to type it in the question box on your dashboard. We do have a few questions already. So one person was asking, in terms of, in addition to reviewing your study from documents in the Nexus, what are some initial suggestions and steps that primary care residency training programs who have faced some of the various logistical and financial challenges can keep in mind when embracing the Nexus?
So I wish I had the magic bullet for that. I would say just like the innovation that's being introduced in practice, there really is no standardization or approach. I think what you heard is our starting to understand what is reality in practice. One of the things I did not mention is about 2 weeks ago we launched a part of our website that we call Amina's Story in the Nexus. And it is a video that based upon a paper that a colleague, Dr. Mark Ernest at the University of Colorado and I did about how do you align practice in interprofessional education to the triple aim. So I would strongly encourage you go to see that resource guide. I think it's page 17, has a lot of resources there, but a lot of this is about starting the dialogue of how do you develop these partnerships to address this bringing the partnership together.
Fantastic. So I'm seeing a couple of questions that I can actually help answer. So a few of you are wanting to know more about like what types of professions were included in the training programs and were a little more characteristics of the programs. And I want to encourage everyone to visit PCPCC's database. This program is actually, or the database is searchable, and it will allow you to look at the various components of the programs, including what types of professions they're training on, what type of program, is it an educational institution, is it a government-run program, those types of things. So the first question was on dentistry. Was dentistry included in the professions trained? And so unfortunately in the 7 programs that are included in this publication, dentistry was not included. But in our database, there are 10 programs that are either training oral health professionals or are training other professionals on oral health and being able to work with oral health on their care teams, oral health professionals. So you can look at the website, that's on pcpcc.org. The second question wanted to know about whether the programs, whether they're not just university settings. So are there programs currently that come from smaller private sector? And again, our database does show this. So there's actually quite a few. If you're searching on the database, you'll see that Geisinger and Kaiser Keystone Health System in Pennsylvania and Kaiser Permanente and other non-educational or non-university settings are training on interprofessional primary care. Barbara, do you want to talk about the nexus as to if programs in the nexus are training on oral health or are not necessarily university settings?
Sure. I don't know if I could answer that specifically, but there is no question that because we do a lot of work with non-academic health center, non-university-based programs also, and there is no question that they are adopting interprofessional education and collaborative practice, so bringing that together. And some of them are actually using the IPIC competencies as a guide. Relative to the oral health piece, there are some really good resources that are starting to develop. There's a program that is training nurse practitioners and physician assistants, the name escapes me, about oral health. We have a great partnership with the dental colleagues across the country, and just like mental health and behavioral health, you know, thinking about how we act and think differently about oral health in primary care settings is, again, another focus that we all need to do. The biggest issue is when you introduce students, we need to help them understand that the focus is on oral health and how do we incorporate them as members of the team.
Great. So this next question I want to direct towards Marci. What's next for the programs? How can we get more programs to recognize the needs for interprofessional team training and development? What's maybe the political appetite for this type of training? And what does this mean for patient-centered medical homes in advancing this care model?
Thanks, Tara. It's a terrific question, and it's one that I think is very much on the forefront of lots of health professions leaders' minds. For those of you who haven't had a chance to see the Institute of Medicine came out with a new report on graduate medical education and reforms to graduate medical education just within the last 3 or 4 months. And I suspect that we'll be having a lot more dialogue about ways in which we need to be training our health professions differently, mostly because we spend a lot of money. There's kind of a lack of transparency around where that money goes. And because the push amongst so many different health professionals from all over the country is to get us out of the fee-for-service system that pays providers to do more instead of to provide better valued care. These things, I think, are very much in alignment. When you start paying providers differently, you're going to move from paying individual providers sort of on a piecemeal basis, and you're going to start paying for team-based care. Well, as you start paying for team-based care, you quickly realize we don't train for team-based care. And there's where I think the alignment of payment reform with education reform is going to become increasingly more visible to folks in public policy circles. And the second question that you'd asked, Tara, is I think relates directly to the PCPCC's agenda, which is do we intend to do more of this work? I think that was the implicit question, and the answer is a big, loud yes. We're embarking on a strategic planning process that we will be finishing up this spring, and I suspect that investing more in primary care, and specifically in the ways we pay for primary care to promote team-based training, is going to be at the top of the PCPCC's agenda. And as I mentioned, as soon as you start saying we need to pay for team-based care, we need to train for team-based care, and it will be a 1-2 punch. Again, that will be a collaborative process, so we'll be looking for people's feedback on our strategic planning. But I think the timing couldn't be better to be coming out with this report, and Congress will surely need a nudge from everyone if we're sincere about paying for care differently, to start with how we pay physicians in Medicare through the sustainable growth rate formula.
Could I just add 1 second? I wholeheartedly agree with your statement. I think there are other external drivers. I think the Accreditation Council on Graduate Medical Education standards, and also the maintenance of certification with the American Board of Medical Specialties. As I'm going into clinics now, I'm actually finding that that's a driver for teamwork. Very interesting comments from teams.
Good points, Barbara.
Well, on that note, we'll take the time to thank everyone, both Barbara and Marci, for presenting today, and all of our stakeholders. Of course, a big shout out to the 7 programs that participated in our interviews, and going back and forth with my team to get this report ready. So thank you everyone for joining us today on our webinar. We hope you can join us at PCPCC's briefing on Capitol Hill. Again, that's on January 30th at 11:30 a.m. In Washington, D.C. You can register for that event on PCPCC's website. And as a reminder, the slides and this recorded presentation from today will be posted on our website within the next 24 hours. Barbara said it will also be posted on her website, on the Nexus website. So once it's available, you can access that at pcpcc.org/webinars. And I hope that everyone has a wonderful rest of your day. Take care.
Thank you.
Thank you.